So from the inferior leads here, if it's going upward from the tip up to the rest of the heart, these should be negative, they're all negative. If it's leftward, 1 and AVL should be positive because it's going to the left. And it's going from the front, the right ventricle is in front of the left ventricle to the back, then every one of V1 through V6 should be predominantly negative because they're all in the front leads, they're all those chest leads you put on the front, and it's going away from each and every one of them in various different slight variations, but away from them. So this sort of looks like a left bundle, but not exactly. And it's because of where the pacemaker is placed. So I just thought that was interesting. I don't know if everybody knows where pacemakers get attached
What
inside
about
there.
biventricular?
Biventricular pacemakers just look weird.
Okay.
And His bundle pacemakers look weird as well, because you can try to plug a pacemaker directly into the His, and then it tries to use the bundle branches if they're still functioning.
I just threw an old pacemaker out that came out of my stepdad. When I was in nursing school, he had his replaced and he gave it to me. He's like, here, I saved this, I thought you'd like it. And I
Yeah.
kept it, and I was cleaning my bedroom. And I know, I just threw it out like last week. I'm like, oh, I probably don't need to save this forever. It was a couple, 2-3 years ago.
Yeah.
So you said some pacers are set on the apex and some aren't. Is there a reason where it's places where the muscle is weakest, less conductive?
Well, interestingly, they usually, it wants to go to the apex because it's kind of a pointy shaped ventricle, and it just kind of is a nice place for it to lodge and stick. And then you have to kind of burrow it into the muscle a little bit so it sticks there, and so that's a nice spot. The apex is a little tougher than the free wall because it's a little thicker. Some people try to guide their right ventricular pacers into the septum because it's even thicker yet. And so there's variation in terms of where they actually get them to stick. And sometimes you want it to go in place and just won't. And so you're stuck with wherever you can get it. But Dan Lusgarten up in Burlington and some other people have really tried to work on their technique at getting the pacemaker to lodge in the His bundle, which is right here. And if they don't get it exactly in the His bundle, then you're in the upper septum. And if they do get it in the His bundle, then hopefully when the pacemaker fires, it will go down the His Purkinje system and activate normally and look normal in terms of the QRS. It's hard to get, it doesn't always work. The thresholds tend to be higher, it doesn't stay as well. Biventricular, they actually put it in, they put this lead, these two leads just where you see them, and this one just kind of sticks down in here like usual. But in here, they'll take one and hook it into the coronary sinus, which is the heart's main vein, and it goes around the back of the heart and comes out in some of these branch veins, and they just use the vein as a place to guide it, and they just stick it and lay it along the free wall here. And hopefully they can get electricity to go from both sides at the same time and mimic having two bundle branches. So the right bundle branch block is just the opposite. It's delay or non-conduction in the right bundle as compared to the left bundle. Things happen down the left bundle, and then it comes from the left to the right and activates the right bundle, the right ventricle later. Now the right ventricle, or the right bundle, is more superficial, more easily damaged, and therefore actually shows up as a normal variant in more people. So 2 or 3 people, maybe even up to 13% if you count incomplete right bundle branch blocks as well. So it's always interesting. You know, our fellowship had 4 people each year, so there were 12 of us. There was almost always one person who had a right bundle branch block and found out about it during fellowship and then freaked out because they were doing all about their heart and they found out their heart was bad. So it was Dave, by the way. It wasn't me. So stretch, which you can get from the enlargement that happens during normal athletic heart, or people with bad lungs can stretch the right ventricle. There's lots of ways that you can injure the right bundle and end up with a right bundle branch block. And it's the left bundle, I put this in here, the left bundle can get damaged or actually goes bad at multiple spots around there. The right bundle is usually right at the very beginning of it because it's just that's where it's most superficial and most susceptible to any damage or injury.
What about airbag injuries?
You could get, from a cardiac contusion, you could get a right bundle. Yep, you can get it from cardiac surgery, you can get it from putting a Swan Gans catheter in. In fact, that's kind of one of those sort of residency, like intern stuff, you know, you grill in interns. If you're putting a Swan in somebody with a left bundle, you need to be prepared to pace them, because you might damage the right bundle and you might go into complete heart block, at which point the cocky intern decides that they're no longer quite so cocky anymore, and maybe they do want a little help with the procedure.
Well, at least they've got access.
They've got access, exactly. You know what to do with it, but they've got it. So there's a lot of things that can also, it's not always a normal variant, there's a lot of things that can also cause or be associated with right bundle branch block. Anything that strains or stretches the right ventricle is a good bet, so cor pulmonale, pulmonary embolism, the catheters like we talked about, surgeries. Every bundle that's good enough at slow heart rates may not be able to regenerate or reset fast enough during tachycardia, so you can get rate-related tachycardias. And so it may be normal at 60 beats a minute, but if somebody gets to 110 beats a minute, they may show a right or left bundle, and so tachycardia by itself. And again, electrolytes, you know, really low magnesium or potassium or calcium can do so many things, including EKG changes, including bundle branch blocks. So again, this is nice, you don't have to remember lots of different numbers. The QRS, 120, greater than 120, same as left bundle, it just needs to be wider, and it's 120. So the big deal about a right bundle branch block is, just like left bundle, you look at V1 and V6. But in a right bundle branch block, you'll get typically what's called an RSR prime formation in V1, which means you've got bunny ears, up, down, up. That's a right bundle. And that's the one ventricle being activated followed by the other ventricle being activated. In V6, the left ventricle is so big and has so much more muscle, you still get a big R wave in V6 in most cases, but you'll also get a slurred S wave as you see this right bundle activating that way later. I'll show you a picture and we'll talk about it. And if it's under 100 milliseconds, it's just a normal variant. You can get an RSR prime that's just a normal variant. And it's just, that's what people look like sometimes. So V1 and V6, again, you can just do the whole thing in 2 leads for bundle branch blocks for the most part. So you'll get, in V1, you'll get the septal, unopposed septal activation, and you see the upright, and then you've got left bundle, which is the downward, and then you've got the right bundle coming in late, which is the second R wave, the big R wave there. And in V6, you've got the left bundle happening, and then eventually the left ventricle happens, and then the right ventricle happens later. But as far as V6 is concerned, the right ventricle is all happening away from it, from left to right. So when that happens, it's negative in V6. And so you get this slow, late negative wave in V6.
And the T wave is only generally opposite in V1?
The T wave is opposite the terminal vector.
Okay.
So it's opposite the last
okay.
part. So downward in V6, the T wave goes up, upward in V1, the T wave goes down. Not the main part, but the last part. Why did I put 2 of these in? Oh, I put right bundle and left bundle together, next to each other. So you can see the opposite. So this one you'll probably want to look at for just a minute. So the upward and downward of a wave on an EKG is reflective of going towards or away from that lead. So to understand the directionality of all that, you just kind of have to know where the lead is. So the nice thing with bundle branch blocks is V1 is here and V6 is here. 1, 2, 3, 4, 5, 6, right? So if you think about where they are, then you know which direction things are going. If something's up in V6, it's going this way. If something's down in V6, it's going this way, basically. Unless it's a pacer, then it's going backwards. So if you look
for
at,
the pacer line.
right, and you look for the pacer line, and the thing at top that says ventricularly paced rhythm.
Yeah.
So So that's why, you know, the importance of, you know, putting leads in the same spot, so you're looking at the same thing, but knowing where the leads are. And the V1 through V6 are nice, because they use the dead center of your body as their second component of the circuit, and it's from here towards the second, so basically it's just here, wherever it is. The limb leads use two things, and they've got real directionality, the positive and negative on each arm. I'm looking at negative to positive on each arm, or leg. Questions about these as you look at them?
You said bunny ears on the right bundle?
Yeah,
branch?
V1.
Because they go opposite. Oh,
Because
the
you have
two V's going up.
Two,
Oh, okay.
you've got up,
Alright.
up. They're not the same size ears, it's kind of weird. but-
Okay.
I'm going the wrong way? No, I'm going the right way. I know I didn't. Skipped a second, didn't I? So that's a full EKG with the right bundle. And it just shows the same thing. So V1 and V6 are the action. The rest of them, it's wide everywhere else, but the limb leads don't really tell you about the QRS conduction. They'll tell you more about the axis. And the interesting thing, the cool one, it's, maybe it's not close to you. So you can get a right bundle, and if you look at 2, 3, and AVF, 2 is upright, 3 is down, AVF is sort of, I don't know what AVF is, I don't know if it's up, down, or isoelectric. I have no idea. So what this tells you is that you just have a right bundle. Now, if lead 2 was down, and 3 was down, and F was down, you would have a right bundle and a left anterior fascicular block. Because the axis would be more negative than negative 45. I didn't show you one of those, but that's to
Thank
kind
you.
of put it all together. So an incomplete right bundle branch block looks like a right bundle. Again, you may not get as much T-wave inversion, but it's not 120 milliseconds. So I measured this before, so it really isn't 3 small boxes, it's kind of like 2.5 small boxes, so it's more than 100, less than 120. What does that mean? Not much, kind of the same as a right bundle. You probably have the same list of things to think about, normal variants, lung issues, prior surgeries, all that sort of stuff. But it would be unfair to talk about all this and not show you one of those. Well, this means we're near the end. Okay. So this is kind of an interesting, just summary slide. There's really nothing new on this slide, except for they drew in those squiggly arrows instead of me waving my hands in directions. So left bundle branch block, it's got the criteria for it, it's got pictures for it, it's got V1 and V6. It's just got all of the things we talked about with a big blue arrow that shows you've got the right bundle, and then the black arrow shows the later cell-to-cell conduction going across. So probably you can guess the next slide is the summary slide for the right bundle branch block, which has the same blue arrow, the same black arrows, the same basic format. We've got V1 and V6, although interestingly, I just don't like how they put them on the wrong sides of each other, but
Right.
what can I say?
This is good, now I know what to look for.
I feel like I need to go home and study.
So, this is the first one I've been to. You did one before, but I wasn't looking, so. Could you print out the slide they have, where you can print out the slideshows with little, where you can take notes, so that we can have?
Can we do that? We
Yeah,
can do
I
that?
can
We can
show
email
you.
people
I was gonna say, he's
stuff,
gonna,
or you
it's
can-
Or
recorded.
email the
It's
slide?
It's
I already
recorded,
emailed
so.
you.
Yeah, I have all of them.
Yep.
Yeah, so
She
if
was
you-
just thinking,
So-
moving forward.
Yeah, moving forward, so if you email the slideshow to people, like, I can print it out, because I am a note taker.
So she.
So
Notes
I
would be
can
good.
note take next to what you're saying in my own.
Mhm. And I'll let Chelsea know that too.
Yeah.
Version.
I mean, I
Yeah, that's
always
great.
intend on being here, but she's.
Chelsea's been posting these, she has are you on Facebook? She has a Facebook group that she started. So if you just let Chelsea know,
Okay.
she's been posting them so you can access.
Oh, you can
But
email
to have it in
her.
advance, to take notes on it next to the slide makes
Yeah,
sense, right?
because so that when, you know, because you'll say something and I'll sort of put it in there next.
Yeah, right, yeah, remember this part, yeah.
Yeah.
Yeah, absolutely. Okay, are there questions about left bundles, right bundles, any of the bundle type stuff? Are there questions, do we wanna go through,
I just want to
access
kind
more?
of address access.
Yeah.
As a regular nurse working on a floor,
Mm-hmm.
how often are we really going to need to know access?
Do you really care?
Exactly.
Yeah, understood.
I mean, it's interesting information and stuff like that,
Mhm.
but 26
Mhm.
years working in an
You
ICU,
okay, right?
I was taught 3 times how to do access and it's like,
So I'm not gonna teach you how to do access, except what I would like to point out, and the reason I did point it out, so knowing that there are 3 components to the infranodal conduction system. There's the right bundle, left anterior and left posterior fascicle. Those are the 3 big wires that can get electricity down to the heart. Once it gets down to the heart, you're okay. But if you've got an idea about the electrical system, you think, geez, you know, I've got a right bundle and it's -60, so I've got a left anterior hemiblock. And I've got a first degree AV block, because I can see that's pretty easy. At some point, you're thinking,
You're gonna go to complete.
yeah, I don't have a lot of electricity left. I've got flaws at every level. I've got, first of all, it takes an awful long time to get there because you've got a first degree block. So something's wrong probably at the node. And then you've got a right bundle branch block, that's not working. A left anterior block, that's not working. The one thing that is working is the right, or the left posterior fascicle. But if you've got a first degree AV block, either that's slow in its own right or the node is bad. You're actually looking at somebody who's relatively high risk for heart block.
Would somebody be functioning at that
Mhm.
level?
Yeah, they'd be functioning because every heartbeat from the top would be getting there. It would be a little bit delayed, but it would be the same delayed every time. So you've got heartbeats every time, so everything's fine. But people like that tend not to have full conduction at higher heart rates. They tend to have rate-related conduction issues, and they tend to, when they're sick, have more issues where they might end up in heart blocks. So the reason to think about access is not because you should be calculating the access on. The computer's actually really good at calculating the access. But because
knowing what's up normal.
when you know what's normal and you know, you start to think about, okay, now I've got all of these things wrong, it actually means they're at higher risk for potential trouble that might actually lead to, I need a stat pacemaker at 2 in the morning and I'm stuck in Porter sort of thing.
And then
That's
it's,
the importance of comparing your EKGs when you know.
Exactly.
That's why I'm here, because I get to start telling them they're 2 hours.
But the, and then the thing is like, you know, when you have that information, I guess the next question is like, what do you kind of do with it? I guess it depends on the situation, like if they're sick, like, at Porter and you're like, wow, they've got pneumonia, and they're like, you know, well, yeah, or whatever, but then they could get really sick really quickly, but like as far as if it's a stable patient, I mean, I guess if you're pre-oping them, you might like be sending them over to cardiology, for
Right, now for
instance.
pre-op and that sort of, so, and there, I had a slide somewhere in the middle, and it was, you know, what do you do? Well, you know, if you've got a left bundle, you get an echo.
Right,
Oh, I've got this slide in the middle. Slide 17, obviously. And,
I'll forward this to you.
But, no, so the, you know, left bundle's never normal, so you always get at least an echo, and then
Right.
symptoms drive the
Right.
rest of it, if they're syncopal, pre-syncopal, chest pain, and that sort
Right.
of stuff. Right bundle might be normal.
oh yeah,
If
I
you've
don't
got
worry about that.
lung issues, you know, you might wanna think about, you know, sleep apnea and pulmonary, and then you might want an echo, you may not, you might. But what do you do if things are
They're running on a
stable,
fascicle.
things are steady, and, yeah, and they're not having any symptoms? You know, you probably don't have to do any specific workup now, but if they've got, you know, some borderline pre-syncopal symptoms, and they've got, you know, right bundle and left anterior fascicular block, you know, it may be somebody you wanna get a Holter or a med monitor, because it might not just be orthostatic, it might actually be that they're having intermittent heart block.
Right. If they're totally stable and they're running on a fascicle, like, and they're going in for like a total hip, it's like,
Probably doesn't change anything.
yeah,
Probably
just be
doesn't
like,
change anything.
you just be like, be aware that
Yeah.
you just get to
Or-
show off your skills, like,
Right, or they have this, or, you know, maybe you shouldn't put a Swan Gans, because, you know, that's the only bundle all they've got left.
It's not here anyway.
Are,
you know, when you, yeah, that's right, nobody does it
Nobody
anymore.
does that anymore, exactly.
are the heart blocks folks that are symptomatic, are they ever like really emergent? Or it sounds like, I mean, obviously it can be asymptomatic but in the emergency room, are they really?
Right, so if it's just a bundle branch block by itself, and that's really all that's happening, it generally does not cause any symptoms at all. But if you've got chest pain and a bundle branch block, especially a left bundle branch block, it could be indicative that you're having a heart attack, which is hard to diagnose because the left bundle obscures a lot of the criteria for heart attack. Because it has anterior ST elevation as part of it, that T-wave inversion. So, the main thing that we worry about in the emergency room is actually, heart block as opposed to bundle branch block, where the atrium and the ventricle are not really conducting together. That's usually at the node, but it could be multiple kind of cumulative bundle branch blocks that eventually just add up to complete heart block. But that looks different. I did not put an EKG for complete heart block. I didn't want to get into all the normal stuff.
Well, that's where I need to know when I have, do I need to go get the doctor in the other room and interrupt him?
Oh, yeah.
Or can I set it, or can I set it at my computer and wait for 5 minutes?
Right, so if there's no chest symptoms and they have a left bundle or a right bundle, you can set it down and wait a few minutes. That's not a critical issue. Heart block, where, there's complete heart block and there's AV dissociation and there's more P
Chest
waves than
pain
there
with
are
any-
Vs. Right, chest pain with left bundles, that's immediate, that's like a STEMI until proven otherwise. Right bundle, that is
With
not
left
true.
bundle?
Yeah. Left bundle and chest pain is like a STEMI
STEMI.
until proven otherwise. Right bundle is not, that is not true.
Let me write that down.
Yeah. And complete heart block is always a problem.
Yeah,
So,
they're usually symptomatic.
they're usually symptomatic and they
Yeah,
usually got
because
a heart rate of
sometimes their
30.
ventricles don't pump at all.
Yeah, they've got, so left bundle, your heart rate will be normal speed.
Pacer pad.
Complete heart block, your heart rate will be slow. Because there's no conduction from the sinus node.
I've seen before where people can switch back and forth a little bit. I've only seen that like maybe one on my cardiology rotation, and I can't remember the significance of it.
Shifting bundle branch blocks?
Yeah, like that, other than that, like, it's like one of the things that would like, this
Right.
scary thing.
Right, shifting bundle branch blocks is a scary thing, because it means both bundles are bad.
Oh, God.
One just happens to be particularly worse than the other at the moment, but while it's taking a break, it may actually reset to a little bit better, and then the other one may be the worst one at the time. So it's actually, shifting bundle branch blocks is an indication for a pacemaker.
Yeah,
It basically means
yeah,
imminent heart block,
yeah.
impending heart block.
One of those things we call the, one of the sphincter tightening kind of.
Yeah, he used to have a right bundle, but now he has a left bundle. Okay, so you have all the bundles are bad, this is a problem.
Yeah, okay.
Yeah, that's the way I look at it. Impending heart block.
Do, multiple, cardioversions, shocking somebody multiple times ever lead to damage and?
Not that I've seen, no, interestingly enough, not that I've seen. Trauma can, when you brought up airbags and steering wheels and things like that, things that can cause cardiac contusion. But
Commotion, of
electricity by
course.
itself, cardioversion electricity doesn't seem to. Probably you could if you were electrocuted, lightning or high voltage, and probably you would do something funny to your EKG, but
Tased.
maybe, theoretically.
Probably not with the first one, but because you're so rowdy, it'd be the third one.
Try to avoid those.
Yeah.
Anything else?
Thank you, I appreciate
Thank
this.
You're welcome.
What's next?
I don't know.
What do we
What
want?
next? What do you
Maybe
want?
heart block. Go through like the AV blocks.
Remind me, what was your last topic about?
Stems. or-
Like AFib's a
Really
good
bummed
one.
that I missed that. Maybe you could do some repeats for people who are.
It's on
It's
the,
on the-
Oh.
YouTube.
It's only
It's-
15 minutes
But
though, I
that one
think
get
it cut
recorded,
out, it
yeah,
got
we
cut
don't
out.
record it.
I'm hoping this one, I did what IT said to do, so
Okay.
I'm hoping
All right.
Well, even 15 minutes of
is
this.
better, right?
There,
Because
the
I think
slides
that's
are
important for
available, so
emergency
that's
room.
the slides are available.
Yeah.
Yeah.
I'll let Chelsea know. Make sure everybody
And
that's
the
here signs
slides are
in.
available for that one?
Mhm.
I believe. Oh, that's good.
Yeah, they should be.
Okay. And there's a Facebook group?
Yes,
Yeah.
Order medical
I'm just-
education and something.
I'll just email Chelsea.
Yeah.
So, yeah, heart block or
Quarter
AFib, I don't know if AFib's really a full-on
Maybe I can
topic.
search.
Yeah,
Well, maybe it could go with the heart.
Quarter
Put it in there.
Because
Clinical
it's
education.
I mean, it's
of heart.
upper SVT type
Yeah, I mean,
of superventricular
Um,
Flutter, heart block, that